Okay, I'll go ahead and get started then. All right, so we can go ahead and start in blood. This is not going to take too long because it's not too difficult in one. But basically, she's not wanting us to know a whole bunch of numbers, but she's wanting us to know the bolded terms, and then the few numbers that there are is going to be like how many liters of blood's in the body, and pH for the blood. So the main two functions that we have are transportation and protection. So it's going to move red blood cells or oxygen through the blood, and then protection is going to protect us. The different types of blood cells protect us from invaders. So the blood composition, there's many chemicals dissolved in it, and millions plus cells living in it, and it contains a liquid or extracellular part, and this is called plasma. So it's the cell fragments, and this makes up the formed elements, which we'll get to in just a little bit. It's the chart on the back of the study guide. So then if amount of blood in a person depends on their size and if they're male or female. So a male is going to have a lot more blood than a female. Someone that's a little bit larger is going to have a lot more blood than someone who might be thinner. We have anywhere from might be in the other chapter. Literally, I just did this earlier today. 4 to 6 liters of blood in the body. So that's 4 to 6 Mountain Dew bottles is how I remember that. So volume of plasma in the blood is usually a little more than half of the entire volume of whole blood. So that's just meaning there's going to be a lot more plasma than there is actually going to be blood in whole blood. So when you get your blood drawn and they put it in the centrifuge and spin it, there's going to be a lot more plasma than there is going to be other elements inside of this. So your blood is slightly alkaline, meaning it's more on the basic side. And you want a pH between 7.35 and 7.45 for blood. A neutral is 7, so we don't want it to go the opposite way. If it's too acidic, we call it acidosis, and if it's more towards alkaline, it's alkalosis. So we want to know that there's a difference between a low blood pH and a high blood pH. Plasma is the liquid portion, so it's blood minus the formed elements. Composed of water and many substances dissolved. She may ask questions about albumins, globulins, fibrinogen, and prothrombin. So we stayed after today and kind of broke these down just a little bit. So albumins help retain water in the blood by osmosis. We go over that a little bit later where you can actually have an injection of albumin, and it has to do with the volume of your blood. And when I think of volume, I think of like getting a glass of ice water. You can put ice in your cup and then you can put water in it. And when the ice melts, it's not going to add more water to your cup. It's going to stay at the same level. That's the volume. Globulins are included antibodies that help protect us from infections and circulate in the plasma. And then you have fibrinogen and prothrombin, and these are just steps in a clotting factor, which we'll go over in just a minute. So then we see plasma has to do with your clotting factors, and plasma minus the clotting factors is just serum. And the way that I remember this is if you have cut your hand and it's kind of starting to close up after a couple hours, but there's some kind of like liquid sitting on the top of your skin, that's just serum. That's the water part of it. And then here we see albumin, and IV administration of albumin is sometimes used as a plasma volume expander in people with abnormally low blood volume. So if you, it says it'll draw out about 3 to 4 times its volume of fluid into the blood through a process of osmosis. So this goes back to the volume, how much blood you have in those walls. So then we have different formed elements. There's 3 types of formed elements. Give me just a second. Okay, so I drew a chart on the back of this, and I don't think she's really going to want us to know all the teeny tiny details. I don't think she's really going to care much about granular or agranular because it's basically just what you're looking at under a microscope, and we're not doing that. She wants us to know the functions of these cells. What do they do? So granular leukocytes and agranular leukocytes are just types of white blood cells. So granular would be neutrophils, eosinophils, and basophils, and these are going to be your protectors. So a neutrophil is also called a phagocyte, which we read about before. These are going to eat invaders. They're going to eat bacteria. They're going to eat things that come in that are not supposed to be there. So they're going to protect us from invading microorganisms by eating it. Eosinophils is protection against parasites, parasitic worms, and regulating allergic reactions. So if you were to get some kind of worm, eosinophils would come out and start to fight that. Your basophils produce histamine during inflammatory responses and produce heparin to prevent clotting in blood vessels of the body. So basically, when you get stung by a bee, that's how I relate the two is basophils and bees. When your skin starts to swell, it's not because of something that's coming out of the bee. These are your basophils producing a histamine, causing it to swell. So when you take a Benadryl, an allergy pill, it's an antihistamine. That's what's pulling swelling down. It's pretty much telling your body to chill out, that it's going to take over from that point forward. So agranular leukocytes is the other type of white blood cell. These don't have stained granules and cytoplasm underneath the microscope. But you have monocytes. They eat bacterial organisms and cancer cells through phagocytosis and transform into macrophages. So your monocytes are smaller, and then they're going to grow to become macrophages. It's just a small and larger version, but they do the same thing. And then you have lymphocytes, and these function in the immune mechanism, meaning there's B lymphocytes and T lymphocytes, so B cells and T cells. Your B cells secrete antibodies that attach to specific antigen molecules related to bacterial, viruses, chemicals, toxins, and foreign substances. And then your T cells are more related to cancer, bacteria, or virus-infected cells. So key note that I use to remember is your T cells are specifically for cancer, and if we could figure out a way to produce more T cells, then we would have a cure for cancer. This is why it's so dangerous when we have radiation, because your body's already putting off something to fight cancer, and then radiation not only kills the cancer cells, but it kills your good cells too, your helper T cells. So then we're going to move on to hematopoiesis. So this is the formation of new blood cells, and this happens in red bone marrow. And so a thing that we were kind of wanting to hit on earlier, I'm not sure how deep she's going to get into it, but there's two types of connective tissue in this, and it's myeloid tissue and lymphoid tissue. So myeloid tissue is red bone marrow, and it's the origin of all blood cells, meaning that's where they start out at. So it's found in your bones. And then lymphoid tissue, it says lymphocytes develop in the lymph nodes, thymus and spleen, and then they move to lymphoid tissue after developing in the red bone marrow, where they are still in the early state and mature in the lymphoid tissue. So be sure to know that they don't start where everything else starts. Red blood cells live about 4 months. Granular white blood cells live for only a few days, and agranular white blood cells can live up to 6 months. So as blood cells mature, they move into the circulatory system. And red blood cells circulate for up to 4 months before they break apart. And then once they reach that point, they're kind of worn out and the body just dissolves them. So red blood cells, structure and function. Red blood cells are a good example of how structure adaptation affects biological function. So it's a tough and flexible plasma membrane. It allows these to kind of bump through your vessels without tearing them. And they can also kind of squeeze and deform themselves or form themselves to move through. But their shape also keeps them from spinning out of control while they're inside of your blood vessels. So the shape that's given to them, this kind of dipped shape at the top, is biconcave. If you see that on the test, that's what that means. It's just a shape. So it's a thin center and thicker edges. And your red blood cells are specifically built to carry oxygen, but they don't carry it on their own. There's other components that help them to do this. So, and I'll draw a picture in just a moment. But mature red blood cells have no nucleus or cytoplasmic organelles. This means that they're unable to reproduce themselves. Or to replace lost or damaged cellular components. They usually have a relatively short lifespan, anywhere from 80 to 120 days. When the cytoplasmic organelles are lost, additional intracellular space in each is filled to the capacity with hemoglobin. Hemoglobin permits red blood cells to maintain homeostasis, carry oxygen, and buffer blood. And it also gives them their color, which is red, and red blood cell or erythrocyte literally means red cells. So during hematopoiesis, red blood cells lose their mitochondria, and we remember that this is the powerhouse of the cell. So it loses the mitochondria, so any oxygen carried in the red blood cells by hemoglobin won't be used up by the mitochondria to generate ATP. So basically, if there was a mitochondria in these red blood cells, it would be sucking up all that oxygen and taking that as energy rather than sending it throughout the body. So it's not using that energy. During their lifespan, they'll travel around the entire cardiovascular system more than 100,000 times. And the word I was looking for earlier was shapeshift. It allows the shape of the red blood cell allows it to shapeshift and get to where it needs to go. So now we're going to go down to CBC, or complete blood count. She did say to highlight this. She did say know it. It literally is what it says, a complete blood count. So when you go, basically when you go to the doctor, your nurse is going to draw up some blood. And this CBC is going to be then putting that blood that they drew, which is whole blood. It's the red, the white blood cells, all of the other things that go into it, into a centrifuge machine, and they're going to spin it. And when it spins, it pulls those pieces apart. So at the very bottom, you're going to see all of the red blood cells. In the middle, you're going to see your buffy coat, which contains white blood cells and platelets, which are crucial in clotting. And then the very top part is going to be the most that you see most of the time, because that's what a lot of your blood is, your whole blood's made of, and that's plasma, which is water, proteins, nutrients, hormones. So then you see this picture, it's in the book, but if you have, let's see, this is where we get into anemia, and I'm going to go ahead and draw a picture of that up here. If you have any questions, go ahead and put them in the comments so we can be hitting on those too. All right, so when they do it in the centrifuge, it can look a few different ways. You can have this way, this way, this way. So the bottom is going to be your red blood cells. And you want to maintain a constant level of these. So if there's too much, there's a problem. If there's too little, there's a problem. And it also has to do with what is right here. This is your white blood cells, platelets in the middle. And this is called a buffy coat. So if you have too many red blood cells, this is called polycythemia. If you have too little blood cells, this is anemia. So they're both different types of anemia. They just mean different things. So I'm going to bump back just a little bit. The hematocrit, which is also another test, is packed cell volume, and it provides the volume of red blood cells in a blood sample. So it's just telling you how much is in there. So if they tell you to go get an H&H, it's a hemoglobin and hematocrit. They want you to look for both of those. So we'll talk about hemoglobin. It's a protein made up of 4 polypeptide chains, each with an oxygen-attracting heme group at the center. She doesn't necessarily want us to know that, but she does want us to know when we talked about formulas, Hb plus O2, which is oxygen, is going to give us oxyhemoglobin, just the two names together. And then if we have hemoglobin and CO2, which is carbon dioxide, it's going to give us carbaminohemoglobin. And these are going to pair to carry oxygen or carry CO2 throughout the body. So this is where I'm going to go ahead and draw a picture of how I like to remember the red blood cells function with hemoglobin, because this is my second time in here. This is the first time that it actually made sense to me. So you have a red blood cell, this biconcave shape, and I like to draw wheels on it and think of it as a car because it's transporting. And then I'm going to put a hemoglobin is going to be my passenger, and then oxygen is going to be what I'm carrying in the trunk. So hemoglobin has to be attached to this red blood cell to carry this oxygen throughout the body. And so when those two are together, that's oxyhemoglobin, oxy and hemoglobin. Now, if this red blood cell is carrying carbon dioxide, then it would be, that was O2 for oxygen. Carbon dioxide is going to be CO2. And so these two attracted to one another being carried on this red blood cell would then be carbaminohemoglobin. So this is important in the homeostasis role in acid-base balance. All right, so now we're going to talk about the different kinds of anemia. So we know that the red blood cell is supposed to be a biconcave shape, and in sickle cell anemia, it's going to have this really funky shape, and it's still going to have a little dip in the middle, but The point is that these are supposed to be able to transform themselves to move through the body smoothly so that they can carry this oxygen because that's super important. Well, if they're shaped like this, they're bumping into each other, and most times they're going to create clots. They're super painful. People that have these do not get oxygen throughout their body sufficiently, and it's usually predominant in African Americans. So you're getting an inadequate number of red blood cells to your body, and this is what you need. So the next one that we have is aplastic anemia. And the way that I remember this is she told us that this has to do with red blood cells being destroyed by another element. So chemoradiation and other destruction of RBCs. So aplastic anemia, the way that I remember this was if you are getting chemo, most of the time they're going to put some kind of IV into you, aplastic tip, aplastic anemia. So chemoradiation and aplastic anemia go hand in hand, and it can be something other than that too. It could just be it could be drugs. If you're shooting drugs intravenously, it could be that that destroys red blood cells. So then we also have just a regular, and I'll say regular anemia, but anemia being you're not getting sufficient red blood cells throughout your body, and different. She may ask symptoms for these, so that would be fatigue, irregular heartbeat, chest pain, weakness, shortness of breath, cold hands and feet, pale or yellowish skin, dizziness or lightheadedness, and headaches. So just too little oxygen is going to cause your body to suffer. So then we have pernicious anemia, and this is a lack of an intrinsic factor in the stomach, and it reduces the ability of vitamin B12 needed for RBC production. So B12 shot would be the treatment for this. And remember, she told us a B12 shot is pretty thick. So remember, we did our checkoffs today where you would give a B12 shot. But basically, the stomach lining reduces this intrinsic factor. So then we have polycythemia, which we did talk about, and that is an abnormally high red blood cell count, and it's the opposite of anemia. So if you're getting too much blood, the treatment for this is going to be a therapeutic phlebotomy. So this means we're purposely going to be pulling blood out of your body to relieve these symptoms. And back in the day, sometimes this would be done with leeches. So that's the way I like to remember that. Is if you had too many, you could use leeches as treatment, and this would pull out the blood from your body. She did want us to know, I have a feeling this is going to be a question, that if you are performing a therapeutic phlebotomy on someone, you want to make sure to check their H&H so that you know you're not draining too much, because you don't want to take too much blood from this person. So your H&H being your hematocrit and hemoglobin. So we just want to keep an eye on that and make sure that we're not draining somebody's blood out too much. Then you're going to send them into shock. So the next thing that we talked about was blood typing, and these can get pretty confusing because antigen and antibodies it's too much. It's too close together, and so we get kind of confused when we talk about this. So after class today, we had a discussion about how we can remember this. An antigen is going to be something coming into your body, and so the way that we remembered this is Aunt Jen or Aunt Jen. She came to visit, and we don't like it when she comes to our house. So Aunt Jen and antigen are going to go hand in hand. We don't want whatever that antigen is. We don't want that coming into our body. And so antibody, we're going to associate something that we already have, our antibody. So antigen being a substance that can activate immune system. Antigen is something bad that's going to trigger your immune system to sit up and start to take a role. Antibodies is a substance made by the body in response to a stimulus by an antigen. And I'll also put a YouTube link on the study guide as well to understand this a little bit better. So then we're going to get into blood typing. Used to, when we took these tests, she would make us figure out blood typing. It's not going to be as serious on this, but she does want us to know that if you have A, then you want A. So you have an antibody for this, and you have B would be an antigen for you. You do not want the opposite. So if you have a patient that has type A blood, you're going to give that patient type A blood. If you give them B, you're going to send them into toxic shock, and that's going to end up probably killing that person. So then the next thing she wanted us to know is a universal recipient is AB, and a universal donor is type O. There's not much more that she wants us to know about that. That's just something that I would have down before tomorrow. So the next thing we're going to look at is the RH system. And I'm going to go ahead and pull up a little picture that I had for this. I put on the printables on the website, but basically this is the mom's bellies in different stages. That's what I'm going to look at. All right. So this first pregnancy, I'm going to say first. This is after first. And this is second pregnancy. So in your first pregnancy, you have a RH negative mother. And then here's the baby, and this baby's going to be RH positive. If the father is RH positive and the mother is RH negative, this baby's RH positive, everything's chill with this first baby. Everything's fine. But what the mother's body is doing is building antibodies for this baby. And remember, we produce antibodies in our body. So this baby is going to be considered an antigen, an invader. So this baby's going to make it through because she hasn't finished making a connection with that yet. She hasn't really, her body hasn't put it together that it's an invader to her. So this first pregnancy is going to be fine. She's going to have this baby. Everything's good. Second baby comes along and it is not going to happen. 9 times out of 10, those babies aren't going to make it because the body is saying, this isn't good, this is an invader, and it's going to fight that fetus as if it was cancer. It's going to kick it out. So this only happens during the second pregnancy. And I have a feeling she's not going to really hit on that, but she may ask you, what does the father have to be? What does the mother have to be? And is it the first, second, third, fourth, fifth kind of pregnancy? And we want to know for sure that it's the second. It's going to build up antibodies. So what they do is they give you a RhoGAM shot. So normally, nowadays anyway, when you go when you have a baby or you're pregnant, you go in and get blood work done, and this will tell them if your child is going to have a genetic disease, if your child is going to have Down syndrome, thousands of other things. They can look at this and tell you ahead of time, so they will know whether or not you need to have a RhoGAM shot. It's very, very common that you have that RhoGAM shot. So another thing she talked about that she may not put on here, but she might because it was something that interests her, was blood doping. And this is, we like oxygen. We want oxygen in our brain. We want it to go through our body. It gives us this kind of high feeling when you got that, like a runner's rush, and you got it flowing real good. It's another reason why it feels good when we go and get massages, because they're getting that blood flow running. So people that like to use this are athletes, and it's very, very illegal, but they like to do it anyways, is a blood transfusion right before they go and play a game. So they will give them a transfusion of blood to kind of get that oxygen pumping, and apparently it helps them make them play better. Illegal, but she did bring it up, so it might be on the test. So next we're going to go over, well, I'm going to bump back to this. This is called erythroblastosis fetalis. So I have a feeling we're going to need to know that name as well. Then I'm going to get down into the white blood cells. So we know that we have agranular and granular. That's just stained and unstained. Give me just a second. Okay. We have leukopenia. And the way that I think of it is puny. A low amount of white blood cells. Low white blood cells. And then we also have leukocytosis, and this is going to be high white blood cells. Cytosis, I got sky high. And then there was a few of us that were getting confused as to what's the difference between leukocytosis and leukemia. Leukemia is blood cancer. And the only difference is this is also high white blood cells, but it's going to be accompanied with no fever. So remember, she told us, that's his fever. When you are checking somebody's CBC, If you see that they have a white blood cell count that is really, really high, and they have a fever, that means their body is fighting an infection. But if you see that they have a really, really high white blood count and there is no fever, it's almost always blood cancer, which is leukemia. So one's accompanied with fever and one is not. Remember, we said neutrophils increase during bacterial infections. Eosinophils are effective against parasites, parasitic worms, allergic reactions. Basophils are going to produce histamine, produce histamine, and then it also secretes heparin, which is an anticoagulant. You can actually give heparin as a medicine if somebody is clotting too much. So we have monocytes. These are large leukocytes, and they're capable of engulfing larger bacteria. And monocytes turn into macrophages. And then we have lymphocytes, which are your B and T cells. So then we're going to look at a clotting mechanism. And I did have a picture of this. I'm going to try and find that. Okay. So your clotting mechanism is basically what's going to happen when you cut yourself or you're bleeding pretty heavily. So say I'm in the kitchen and I cut my finger with a knife. My body's first instinct is going to be vasoconstriction. So this is just your blood vessels squeezing together. They're going to squeeze together as tight as they can to try and prevent this bleeding out. So then the next thing it's going to do is send out platelets to kind of plug that as best as it can. Prothrombin is going to be released. And then thrombin is going to come from this prothrombin. This is going to react with fibrinogens, which if you remember from cell chapter before, and I believe skin, we talked about fibrinogens, and they're going to trigger fibrin. And when I think fibrin, I think literal like fibers, just a bunch of little fibers, and they're going to kind of come together in this space to kind of weave back together, almost like you're sewing something back together. So then the last thing that they're going to do is form that fibrin mesh, and then it's going to create a platelet plug, which is your scab. So platelet plug, scab, problem solved. Oh, yay, we're almost through this one. Okay, so then the next thing we see is a thrombus and a bolus. And these are two different types of clots. So I think of it, thrombus, I'm looking at the T at the beginning, and I'm going to think of it as a train station. And the reason why I like to think of it as a train station is because it's going to be stationary. It's a stationary clot. This is one that's not going to move. So you have a clot in your leg, it's going to stay in your leg, it's not going to move. And then we have a bolus. And I like to think of bolus to be as a bus. And buses move around. They're going to drive that clot. It's a moving clot, which is super dangerous. So if you have a clot in your brain, most of the time it's going to cause a stroke. And if you have a clot in your heart, most of the time it's going to cause a myocardial infarction. And we also, I don't know how deep she's going to get into it, but if your patient has, this is your patient's brain, this is the right side, this is the left side. If they have a stroke on this left side, it's going to affect your right side. So if you have a patient and they can't move the right side of their body, it's because they had a stroke on the left side. And this is also called a cerebrovascular accident. She probably is going to ask that question. Instead of calling it a stroke, it's technically a cerebrovascular accident. So she also wanted us to know that platelets clotting is a positive feedback mechanism. It's positive that your body is sending out something to help you. It's doing what it's supposed to be doing. It's going to encourage this clot to form. Let's see. An antithrombic is to reduce a clot. So these are like Coumadin or heparin. These are different medications. She might put that on there, not sure. And then she did tell us that if we have a patient that comes in with a stroke, the first thing you want to do is get a CT scan. CT scan for a stroke, because that's going to let us know where this is at and how it's going to affect us. So that's all for the heart. For the blood. Is there anybody that has any questions so far? Anybody? All right, good deal, Jasmine. I really don't think this test is going to be as hard as everybody's feeling. It's just that the heart is something super serious, and I think we're all just kind of panicking looking at how much information there is to know. But honestly, the past tests that we've had, Jasmine knows when we were here before, she was hitting everything. There was not a single thing that you were going to miss on those heart chapters. She made sure that we knew it. So I think it's a lot better than what it used to be. I'll take this any day. All right, so we're going to go ahead and start on the heart. This one's a little bit longer, but we'll try not to be on here forever. We're making good time. It's only 9 o'clock. All right, so she does want us to know location, size, and position. Yes, when Dr. Mullins taught us, I promise you I want to be a cardiologist when I left that class, because she taught us so much and she made it so much fun. And this was like, blah, we didn't get to know as much stuff, but I think it's going to be all right. I think we're going to make it. All right, so she said location, size, and position of the heart. So if this is the right side of you and this is the left side, you have 2/3 on the left side and 1/3 on the right side. And this is also why we only have a certain amount of lobes on one side in our lung and then more on the opposite. We're going to have more lobes in the right side than we are the left, because the heart is taking up so much space on this other side. And we've already done that, but she might ask you so. All right. So your heart is triangular shaped in like the shape of a fist. And so the bottom or pointy part would be the apex. And this is where you're going to get your apical heartbeat. So she might ask, what is something important about that space? It is in the 5th intercostal space down at your midclavicular line. I'm doing it on the wrong side. This is the left side. But you want to go over to your clavicle and go 1, 2, 3, 4, 5. It's usually right below your nipple. And it is 5th intercostal space at the midclavicular line on the left side of your body. This is your apex. This is the strongest part of your heart. It's the pointed part of your heart. And this is the best place for CPR. CPR on the apex. That's important. So let's see. All right, she wants us to know about the chambers. There's 2 upper chambers and 2 lower chambers. And these are atria and ventricles. Atria and ventricles. Your atria are going to be smaller. Your ventricles are going to be bigger. And your atrias are receiving chambers, and then your ventricles are discharging chambers. So I'm going to do my best to draw hard on here. Don't crucify me. All right. So superior vena cava, inferior vena cava. We have our atria here. Here's a little valve. Here's this is our septum. There's a valve. There's a valve. Here's another ventricle. And then there's a little valve back here. And then here's our other. This is terrible drawing. I'm so sorry. So basically, if you can trace this with your finger over and over and over, you're not going to forget it. But she does want you to know what's smaller and what's bigger, and to be able to trace it through. So if the atrias are receiving chambers and the ventricles are discharging chambers, that's meaning that the atria are going to collect blood from the body, and then the ventricles are going to be what's sending it out. So I'm going to bump over. Okay, so each heart chamber is named according to its location. The wall of each heart chamber is composed of cardiac muscle tissue, which is myocardium. So heart muscle, my heart muscle is myocardium. And then you have one septum, but it's divided into two things. So if your atria is here, ventricle is here. This area between the two atria are the interatrial septum. It's the interatrial septum. This space between the two ventricles is interventricular septum. You may not get that deep into it, but just know that it's separated. And then the chambers of the heart are covered in a smooth muscle tissue called endocardium. So I kind of drew this in a little chart just to break it down. Hopefully she gives us a piece of paper. But so we have pericardium. Hey, Cameron. We're going to get right. All right, pericardium is broken down into two. So we have an inner and an outer. Inner is going to be your visceral or epicardium. And then outer is going to be parietal. She may ask us these. I don't think it's going to be nothing crazy. Okay, so then we also need to know that if you see itis, I don't know if anybody's been working in their med terminology book, but anytime you see itis, it's going to be inflammation of something. So she asks you what the inflammation of pericardium is. It's going to be pericarditis. And then I think we had another one on here as well. We'll get to that in just a minute. Okay. Yeah, it was inflammation of endocardium. It's endocarditis. We also need to know that there's serous membranes on our heart, and this is just there's a lot of movement in the heart, so this is going to keep it from causing friction as it's moving because it's constantly moving. And then we also want to remember our thrombus is our stationary clot, and a bolus is a moving clot, and that these can affect circulation through the heart and cause myocardial infarction. So we also want to know that systole and diastole, I'm going to go ahead and erase this. If you guys have any questions, put them in the comments so I can hit that. So we have systole and diastole. This is your top and your bottom when you do your blood pressure. So normal blood pressure would be 120/80. First sound, second sound. All right, I'm going to go over. So then we want to know that our atriums have atrioventricular flaps. There's 3. So these flaps are going to push, and they're not going to allow any of that blood to come back. And the way that I kind of thought about it was those big A Clorox boxes or containers that are in the front of the room, and you have to pull the little piece out of like a Lysol container. They have the little flaps that you pull the sheets out of. It's not gonna be easy to put anything back into those. You just want to pull. It's allowing you to pull something out. So that's how I think of the valves of the heart. So then you have the semilunar valves, and this literally just means that they look like half of a moon, and it's just 2 flaps. So then we know that we have chordae tendineae, and this is going to be when you have a valve. So say this is a valve, and blood's coming through here. There's going to be some muscle-type strings that pull these. They're just going to help pull them open and close. They're literally just attachments to help do that. We also want to know that atria contract together, our semilunar valves open and close at the same time, and your ventricles close together as well. So this comes in when you see lobed up, which is your heart sounds. So first sound, second sound. And the first sound is going to be a little bit longer, and the second is going to be shorter. So when you're listening with a stethoscope, it's going to be bump, 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 bump. And the lobe is the closing of the AV valve. So AV valves are closing and opening at the same time on opposite sides of the heart. So the heart works together, but separately at the same time, if that makes any kind of sense at all. So basically, I'm going to see if I can draw like a little bit squarer version of the heart. But if there's 4 You have your atria, ventricle, ventricle. You have a space here coming out. You have a space here coming out. You have a space here coming out, and then you have a space here going out. And that could have been drawn so much better. I'm so sorry, but you would know that these close and open at the same time, and these close and open at the same time. So sending out, sending out, sending out. I really don't know how to draw a better picture. When we stayed after class today, I could pull it up on her board, on the smart board, and it was a lot easier to explain. But just know that they close and open at the same time. Lub is closing of AV valves. Duct is closing of semilunar valves. We also know what a step is. We've been using them, but this is what we use to listen to heart sounds. And a heart murmur is an abnormality in a normal heart sound. This is also pretty common in children, pretty normal in children, and then it starts to go away after a while. So we also want to look at blood flow through the heart, and this is the one that I put in 12 steps, but there's a 5.5, if that makes any sense. So Miss McGeehee said that she wants us to know, it's not necessarily extra step, it's just extra. So if we have oxygen poor blood coming to the heart because it's been all through the body and it's exhausted because it's been all the way down to your tippy toes and worked its way all the way back up, it's going to be super poor in oxygen, and we want to get that fixed before it gets sent out to the rest of the body. So we're going to have oxygen poor blood, and this is going to come into the right side of the heart, right heart, and it's going to come into your superior and inferior vena cava. That's one. Step 2 is your right atrium. Step 3 is going to be your tricuspid valve, and you want to try before you bi. So you know that tri is going to be on this side and bi is going to come later. 4 is your right ventricle. 5 is going to be your pulmonary semilunar valve. 6 is going to be the pulmonary trunk and pulmonary artery. This is the part that you want us to add as the pulmonary trunk. But if you're looking at a picture of the heart, you know that it has to go through the trunk to get to this. She just wanted it to be in there, so we know that it has to pass through. Anyways, all right, so pulmonary trunk / pulmonary artery. And so now this oxygen poor blood has been sent. It's coming out, and it's going to go to our, well, you can't even see down there, I'm sorry. It's going to go to our lungs. And these are terrible, I'm sorry. Okay, so now that it's out to the lungs, because what happens in your lungs? You swap out CO2 for oxygen. So you're getting rid of carbon dioxide, which is poisonous to your body, and you're bringing in oxygen. So now this is oxygen-rich blood. It's made its way to your lungs, and now it's coming back up as OR. We're going to say oxygen-rich. And then now we're going to move on to our 7, 8, 9, 10, 11, 12 steps. And then we've made it all the way through the heart. So now it's going to come back through your pulmonary vein to the left atrium, which is the top part. Then your bicuspid valve or mitral valve, which she may ask either one, so I would definitely know what both of those are. It's the same thing. Your left ventricle, your aortic semilunar valve, and then aorta, which sends it out to the body as a whole. Okay. Let's see. Okay, so also if you get a piece of scratch paper and you write 1 through 12 and you're getting stumped on something, look at what's related to it. Like 2 and 8 would match up. Your atriums are going to match up. Your valves are going to match up. This is another valve. This is your ventricles. And then this is your exit points. This is your inner points where it's coming in. Atria, valve, ventricle, valve, out. And it's just divided on separate sides of the heart. So that's the best way that I know how to do it. That's how I'm going to do it tomorrow. Hopefully she gives us a piece of scratch paper. So we're going to move on. So when the heart beats, the the atria contract at the same time. This is atrial systole. And then after ventricles fill with blood, they contract together, and this is called ventricular systole. So the atria are going to go at the same time, and then ventricles, atria, ventricles. left and right side of the heart act as separate pumps, but the pumps are going to coincide with one another, if that makes sense. So then she wanted us to know, I think I've seen this question quite a few times, what pulmonary circulation is. Pulmonary circulation is the flow of blood from the right ventricle to the lungs and back to the left atrium. So this is when it leaves pulmonary trunk, pulmonary artery to go to the lungs and back. That's pulmonary circulation. When you think pulmonary, think lungs. And then systemic circulation is the blood flow of blood from the left ventricle throughout the body and back to the atrium. Okay. So then blood flows into the heart muscle through two small vessels, the coronary arteries, and these are on the outside of the heart. You can see those on, there was a picture of this, 283 in your book. It's a really red. You're not going to miss it. But this is on the outside of your heart. And I believe, somebody please correct me if I'm wrong because I don't have this in my notes, but I think she said that's what was called the widowmaker. If something happens to that, please leave me a comment. So veins are the vehicles for blood to be sent to the heart, and arteries send away. That's just how I looked at that. We talked about embolism. It's an obstruction of a blood vessel by foreign matter carried in the bloodstream. So with a clot, blood can't pass through occluded vessels. They can't reach the heart. They can't carry oxygen. You're not going to be getting what you need. Myocardial infarction, I'm almost 100% sure she's going to put a question about this on here, but that's a heart attack. And it's just tissue death because blood's not carrying oxygen properly. This is most common cause of death in middle and late adulthood. And where do you usually see a lot of this at? Where we live. Where we live is the worst because we like to fry everything, and that is going to cause a plaque buildup. I like butter and anything. My husband's looking at me. I like butter, and I put it in everything times 10, and it's definitely going to mess with my arteries, but it causes a plaque buildup, and this is just a stopping point for blood flow. It's just not going to happen. So angina pectoris is severe pain in your chest, and it's used as a warning sign that there could be an obstruction in your blood vessel. So angina pectoris is a pain in your chest. It's like sharp shooting pain. So there's a couple things that they can do about a block in your heart or a heart attack, and that's a coronary bypass. So this is a common treatment for those who've had severely restricted coronary artery blood flow, and veins are harvested from the rest of the body to bypass partial blockages because they can't necessarily always go in and get them out. Sometimes if you mess with them, it's going to cause them to come loose and travel, and then you don't want that either. So a lot of times people that have had heart attacks and are having issues with their heart, such as that, you'll see that they have had veins or arteries they've had them removed from the inside of their arms, they've had them moved from the inside of their thighs, they've had them moved from their back, they've had them moved from all over the place. Anywhere that you can harvest these veins and arteries, they'll remove them, and then they'll use them to kind of split this off, if that makes any sense. So it's almost like a detour for your heart. Once you've reached a certain point and it's not working as well, you still have to get that blood flow, and that's the best they can do because we're not going to take care of our bodies the way that we should, and we know that. So basically, this is my artery. Here's all this hamburger that I've been eating my whole entire life and not giving a crap about. And so now there's not any kind of blood flow. It stopped. Nothing's coming over here. I'm not getting that to my brain. I'm starting to get angina pectoris, making my chest hurt. So something that they can do is a bypass, which is pulling out these extra veins or arteries, and they're just going to take it and they're going to go around it. They're just going to kind of reroute it. And the best way that I know how to remember this is my papa's had so many heart attacks, so many of these things done that the inside of his veins probably look like the construction sites in Memphis. They're just rerouting everybody. So then the next thing that they can do is an angioplasty, and this is a device that's inserted into a blood vessel. And so another word for that would be a stent. A lot of times we like to call them stents around here. But they put something in your heart, and it's kind of like a balloon, or it'll have like a chain link fence kind of look to it, and they just put it in and blow it up, and this is going to spread it just a little bit and allow stuff to start flowing through. But a lot of times they want to try and pull this apart first so that they don't open that and just send that through like a clot because that's super dangerous. Let's see. Okay, there was something else that they put in here. . 'Cause 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 ' I don't need we'll get to it later, I believe. But another thing that you could do if your heart's not getting enough blood flow, and it's not necessarily because of a blockage, but just maybe heart disease, things like that, is a pacemaker. Pacemaker. My great grandmother had one of these, and it's basically this little box. It's almost like a generator. So if you have a generator in your house and the lights get cut off because it's storming, it's going to pop those lights back on real quick. It's going to send that electrical signal and get everything rolling again. So if your heart's starting to get out, or it's kind of reading that it's not as strong as it once was, it's not doing what it was, it'll give you a shock. And a lot of the times we see it in like Grey's Anatomy, TV shows, movies, is that they don't have a pacemaker, they don't have anything to shock these people with, is they will slam their fist down onto that person's chest because it sends out a shock really quick and gets it pumping again so that your body is flowing blood the way that it's supposed to. So then we talked about a cardiac cycle. Cardiac cycle includes a contraction, which is systole, and relaxation, which is diastole of atria and ventricles. Each cycle takes about 0.8 seconds to complete if the heart's beating at an average rate of about 72 beats per minute. Most of the atrial blood moves through the ventricles passively before the atria have a chance to contract. So this is super fast, and mindlessly we're doing this. Let's see. Okay, then I want to talk about the conduction system. And I'm going to try and make this as short for you as I possibly can. But if we're looking at the heart, and really the only thing that I'm going to draw out for you, I'll have the atria in here, and then I'll have the ventricles down here. But you're going to want to be looking at this septum. The part that separates both the atria and ventricle. And you can't see this because it's electrical. So the way I think of it is literally an outlet in the wall. You can't see all the wiring that's behind the sheetrock, but you know that there's something back there that's making it work. I know if I plug my phone in, most chances it's going to work. So you have your atria and you have your ventricles, and we're talking about conduction again. Over here in your atria is going to start it out. You're going to have your SA node, which is your pacemaker. This is the first in conduction system. Okay, so the second thing that you have is your AV node, and it's going to be about right here. This is literally just a chain of events to cause the heart to contract to send out blood. It looks super extra, they make it super extra, and it's really not. So then the next thing that you're going to see is your bundle of His, and this is going to be right here. This is your third step, bundle of His. Okay, and then you're literally just branching off from that. So the next thing that you're going to have is your you have AV bundle or your bundle of His, and then it's going to form off into branches. And these branches, give me just a second. I'm trying to find where I'm in the book so I can pick you guys up. Okay. SA node, AV node, your bundle of His, and then your branches. These little pieces on them, these are your Purkinje fibers. I think that's a J. Yeah, I think that's supposed to be a J. So you're literally just causing a chain of events for this heart to contract. This has to trigger this, has to trigger this, has to trigger this for your heart to do this. And that's pretty much all there is to that. It's not nearly as crazy as it looks like it should be. All right, so we talked about, you need to know that the SA node is a pacemaker. I have a feeling that's going to be a question. Myocardial fibers are electrically linked together and normally match the activity of the fibers that make up the conduction system. So when an impulse reaches the AV node, it's triggered to relay its own impulse by way of AV bundle, of AV node, AV bundle, and into the subendocardial branches to the ventricular myocardium, which is this is heart muscle, causing ventricles to contract. So we're going to see that swooshing motion, and that is just this lineup. So endocarditis or myocardial infarction can cause the heart conduction system and disturb its rhythmic beating. So this is called a heart block, and this is where we talked about having maybe a pacemaker or having a stent put in or a harvested organ. So heart block is just literally a block in the heart. It's something that's keeping blood flow out. Then we looked at the electrocardiogram. She didn't want us to know how to read that on the test. We're not going to have to do that. That was just for medcoms. But the heart's conduction system generates tiny electrical currents that spread throughout the surrounding tissue and eventually on the surface of the body. So that's how we read. This is telling us the P wave, the T wave, the QRS complex, all of that is just from this conduction right here. Kind of like if you've ever worked in construction or you've worked in a house and there's a piece that you can put into a wall socket to tell you if it's actually, what's the word called for it? When you put that piece in the wall to tell if the outlet's working. A what? A receptacle tester. Pretty much that's what electrocardiograph is. It's going to tell you whether or not this is working and what's missing. So if you have a blockage in a certain part of your heart, it's going to be able to pick that up. You're not going to see it on the waves. So then I put on the study guide as well, the normal electrocardiograph, and this tells you P wave, QRS complex, T wave. But she's not going to make us do that. But it is helpful to know it because if you know where something is, you can kind of tie it in with the 12 steps and you can tie it in with conduction. So depolarization is the electrical activity that triggers contraction of the heart muscle, and then repolarization begins just before relaxation phase of cardiac muscle activity. And if there's something wrong inside the heart, the EKG should pick it up. ECG tracings are extremely valuable in diagnosis and treatment of heart disease. So then we also looked at cardiac output, which is the volume of blood pumped by one ventricle per minute. And it averages about 5 liters in a normal resting adult. So we pump about 5 liters of blood through our heart every minute. Okay. Cardiac output is determined by the heart rate and stroke volume. So this is how fast and how hard. Heart rate refers to the number of heartbeats, cardiac cycles per minute. So a whole systole, a whole diastole is going to be a heartbeat. Stroke volume refers to the volume of blood ejected from the ventricles during each beat. So this is telling you about how much blood is coming out, what's being sent. So heart rate is determined mostly by the natural rhythm of the heart created by the heart's conduction system, and abnormally decreased oxygen can result in fatigue or a significant drop in your cardiac output, even death. So if you don't have enough blood to circulate through there, it's no good. So then we have heart rate. The heading heart rate, and we're going to look at it. The autonomic nervous system can alter the heart's rhythm to increase or decrease heart rate. So this is when we talked about parasympathetic and sympathetic. We want parasympathetic is when you're at peace, your heart rate's going to be pretty chill. It might even be lower because you're sleeping. And if there's a fight or flight kind of situation that comes up, your heart rate's going to rise because you're getting ready to fight or flight. It's your body's stepping up to the plate to take on whatever's coming. So we also talked about norepinephrine. Adrenaline was the word I was looking for in the podcast, but norepinephrine is a neurotransmitter that's causing the AV node to increase its usual pace and increase heart rate. So if there's somebody's chasing you with a knife, norepinephrine neurotransmitter is going to be submitted through that synapse in your neurons. And then the SA node is going to increase that heart rate. It's going to shoot a lot faster. It's going to make it beat a lot faster than what it was because you're trying to get up and go. So when CO2 levels rise during exercise, it's a reflective rise in heart rate, and this is an attempt of the body to restore homeostasis in blood gases. So when you are working out and you're pulling in a lot of oxygen, you're going to be giving out a lot of CO2. You're going to be giving out a lot of carbon dioxide, and this is just your heart pumping faster is trying to get oxygen to your body faster because you're moving so fast. So a sudden drop in blood pressure triggers a reflective increase in heart rate as the body attempts to restore normal blood flow out of the heart. So the lower your blood pressure is, the higher your heart rate is going to be because it's really trying to work overtime and really trying to get you up and going. Stress can also cause a sudden increase in heart rate, so skeletal muscles will be ready to resist or avoid the stressor. We know stress. We're about to feel stress tomorrow, and I promise you my heart rate's going to be up. Then we have stroke volume, and it's the volume of blood ejected by the ventricles, and it's determined by the volume of blood returned to the heart by the veins or venous return. Generally, the higher venous return, the higher the stroke volume. Venous return can change when the volume of blood changes, as in dehydration or blood loss due to hemorrhage. Various hormones can influence this. Movement of skeletal muscles, including breathing, influence pressure on veins, which increases venous blood flow and increases rate of venous return. Strength of myocardial contraction also helps determine stroke volume. So if you have a really weak heart, you're not going to have a very good stroke volume. Ion imbalances can affect muscle fiber function and impair contraction, and this would decrease stroke volume. Valve disorders, coronary artery blockage, or myocardial infarction decrease stroke volume and might decrease cardiac output. So we have different types of blood vessels. I feel like there is something missing from this that we did not go over. Maybe it's the back. Yes, we didn't skip it. It just ties in what I was just talking about. Okay. Let's see. We have arteries, and these are arterial blood is pumped from the heart through a series of large distribution vessels called arteries. Now, arteries are going to be thicker. They're going to be bigger because they're sending blood out. Arteries send away. So this big artery at the top of your heart, your aorta, has to be strong enough to shoot blood all the way out of it, all the way through your body, through every teeny tiny little crevice, all the way down to your tippy toes, and then it's going to take its time coming back. I like to think of the aorta as a water pressure or a water hose. When you turn a water hose on, first thing that you're going to hear is that gush, and it's going to shoot it out very quickly if you turn it on high. And that's what aorta does. It's going to shoot that as quickly as it gets through the water hose. It's going even quicker through your heart, but it has to be able to be strong enough to reach all the way down to the smallest spaces. So aortas are going to be a lot bigger. The largest artery is your aorta. They subdivide and blood flows into vessels that become progressively smaller arteries until finally enters tiny arterioles that control blood flow into microscopic exchange vessels called capillaries. And in capillary beds, these are just teeny tiny little vessels. Exchange of nutrients and respiratory gases occurs between blood and tissue fluid around the cells. So this is where we talked about hepatic portal circulation, and we're going to get into that in just a minute. Just keep capillaries on the back burner. Large veins are called sinuses. So the superior vena cava and inferior vena cava that bring blood into the heart are sinuses. I don't know a way to remember that. Just know inferior vena cava, superior vena cava, they're sinuses. They're big veins. Arteries carry blood away from the heart, and veins are going to carry blood to the heart. And capillaries carry blood from tiny arterioles to tiny venules. So we're progressively starting larger and getting smaller, and this is what's shown on our blood pressure gradient. Also, if I'm going too fast for you guys, or if there's something I'm missing, stop me or write something in the comments, and I can answer, or I can go back over something if you need me to. I need a drink right now. The aorta carry blood out of the left ventricle of the heart, and the vena cava returns blood to the right atrium after the blood has been circulated through the body. So there's 3 types of layers found in arteries or veins, and basically this is a protective mechanism. We want to make sure that it's strong enough. We want to make sure that nothing's going to pierce these. And so the 3 layers are not hard to remember because you can link it with a name. So you have external, which is the outer layer, and then you have the middle layer, and then you have the inner layer. And the way that I remember these, I linked it with the name. External is going to be, externa or tunica externa. And this is E and E. And then you have your tunica media. And I don't know who came up with these names, y'all, but I don't want to fight them. Inner is going to be tunica intima. So external, externa, middle, media, inner, intima. That should not be hard to memorize. She did say that was something we might want to know. I don't know how serious that's going to be, but I would know that. And so these are just the layers of blood vessels. All right, so let's see. So stretching, walking, and other activities help improve blood circulation and prevent formation of thrombi in the veins. This is why it feels so good you go get a massage, it's because you're allowing that oxygen to flow. And this is also why they tell us during our physical assessment that when we can massage our patients, and you want to go from their feet up or the bottom of their legs up, because you want to promote that return to your brain. It's almost like you get a head rush. Anytime I've ever been, I've fallen asleep because it's just like a chill feeling. So capillaries cannot be seen because they're microscopic, and these are super, 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 super tiny veins. Capillaries are extremely thin with only one layer of flat endothelial cells that compose the capillary membrane, and capillary walls composed of only one layer, the tunica intima, which is this inside layer. Substances such as glucose, oxygen, CO2, hormones, and waste can quickly pass through it on their way to or from cells. So together, arteries, capillaries, and veins all conduct blood around the body in circulatory routes. It just depends on how much is carried and what else is carried in the blood. So arteries and arterioles, distribute blood from the heart to the capillaries in all parts of the body. So they're going to go from big to small. Constricting or dilating, arterioles help maintain arterial blood pressure at normal level. Arterial pressure is a major force in keeping blood flowing. It has to be strong enough, like I said, to pump from your heart all the way down to your tippy toes. So capillary exchange, there's 3 blocks that I put for this at the arterial end of a capillary. So where it's going from arterial to capillary. The outward driving force of blood pressure is larger than the inwardly directed force of osmosis. Fluid moves out of the vessel. 2, at the venous end of the capillary, the inward driving force of osmosis is greater than the outwardly directed force of hydrostatic pressure, and fluid enters the vessel. So about 90% of the fluid leaving the capillary at the arterial end is recovered by the blood before it leaves the venous end. The remaining 10% is recovered by the venous blood eventually by way of lymphatic vessels. She didn't hit on that super hard. I think we really just need to know what capillaries are and what they pull. So capillary function as exchange vessels carrying out a central function of cardiovascular system. Glucose and oxygen move out of the blood and capillaries into interstitial fluid and then into cells. Carbon dioxide and other substances move in the opposite direction to the capillary blood from the cells. So then we see that fluid is also exchanged between capillary blood and interstitial fluid because these are so small, things can move out in and out easily. There's 2 opposing forces influence capillary exchange, and she may ask this only because we've gone over it before and she likes to do that. But osmosis and filtration, which are both passive, these we learned about before when we learned about passive and active. Osmosis is the passive movement of water when some solids cannot cross the membrane. Filtration is the passive movement of fluid resulting from a hydrostatic pressure gradient. So filtration is going to be something pushing that through there. Capillary exchange forces vary depending on location. At the arterial end of the capillary, the outward directed forces are dominant and tend to move fluids from blood to tissue. At the venous end of the capillary, and inwardly directed forces are greater and tend to move fluids from tissue to the blood. Let's see. Factors that affect osmotic pressure, like a plasma albumin level, or hydrostatic pressure, like blood pressure. Dry filtration can disrupt capillary exchange that might result in dehydration or overhydration of tissues. We don't want either one. We want it to be just right. So venules and veins, these are a little bit bigger than capillaries, but venules and veins collect blood from capillaries and return it to the heart. So because venules and veins carry their vehicles to the heart and arteries are away. So the larger veins also serve as blood reservoirs because they carry blood under lower pressure than arteries. They can expand to hold a larger volume of blood or constrict to hold a much smaller amount. So they're pretty handy. External pressure can turn veins, which have one-way valves, into pumps that help return blood to the heart. Vehicles, veins, they're carrying it to the heart. So there's different routes of circulation. We have systemic and pulmonary routes of circulation. Blood flows through the vessels that are arranged in a complete circuit or circular pattern. Route of circulation is a particular set of circular pathways, such as from the heart to the lungs and back, or from the heart and particular organ and back. So basically, this chart that I have drawn on the study guide is the 1 through 12 steps with the places in between them. So we have oxygen poor blood coming into the right side of the heart through the vena cavus, right atria, tricuspid valve, right ventricle, pulmonary semilunar valve, pulmonary trunk, pulmonary artery, to the lungs, and in the lungs specifically, arteries, arterioles, capillaries, venules, veins. Then we're moving to the left side of the heart, and we have pulmonary veins, left atrium, bicuspid valve, left ventricle, aortic semilunar valve, aorta, out, So it goes from aorta to arteries of each organ, arterioles of each organ, capillaries of each organ, venules of each organ, and veins of each organ. And then the veins are the vehicles to carry it back around again once the oxygen has been exhausted, because we know that the capillaries pull out what they need. So the next is hepatic portal circulation. And so I drew a drop of blood, and then I kind of did arrows through. But blood from the spleen, stomach, pancreas, gallbladder, and intestine are kind of rerouted through the hepatic portal vein. So whatever you put in your body is going to affect you to some degree. So we're going to assume that there's chemicals, alcohol, nutrients, preservatives, etc. In this blood pumping through your body. You can be an alcoholic. And the reason why being an alcoholic is going to destroy your liver and not your big toe is because your liver is the filtration system. So if anybody has ever changed a filter in their house through their air conditioning system, and it's just plugged up with a lot of junk, we can look at a alcoholic's liver like that. It's filtered and it's pulled as much as it can, but it's damaged, and eventually you have to get a new one. So you can have this taken out, and you can have a new one put in, or what is the word that I'm looking for? No. When somebody gives you a kidney or a liver. Transplant. I'm thinking transport. Okay. So you could get a transplant done, but basically your liver is a filter, and since it's so important in pulling out all these things, like if you've just taken some medicine, it wants the good things. It doesn't want the bad things. So it's going to try its best to filter out what doesn't belong, what it doesn't need. So since it's so important, it's going to go through 2 capillary beds before it's sent back to the body. So processed blood exits the liver through hepatic veins and joins the rest of the blood through the spira vena cava. So the liver is going to kind of act as like a gatekeeper, a guard, and it's just a filtration system. It wants to pull out everything it needs. The capillaries wants to pull out all that good stuff, everything that it needs, and then it'll send it out the rest of the way. And our bodies will figure out how to get rid of that. So then we moved on to fetal circulation. She didn't really want us to know a whole bunch about this, but she did want us to know what a placenta is and what a umbilical cord is, and she does want us to know that if in this instance that this arises, you just had a baby, you cut the umbilical cord, but it's still attached to the infant, you can actually use the umbilical cord as a way for an IV solution to be put in if this baby needs something, because it's going directly to their bloodstream. This is how the baby was being fed, from the placenta into the umbilical cord there. So if you know two, you know the other. Then we're going to define blood pressure. So we shouldn't really go over hemodynamics very much, but the 2 things I have is hemodynamics is a set of processes that influence flow of blood. The main force that drives the continuous flow of blood through its circulatory route is blood pressure. We just want to know how the blood's getting there. So blood pressure is the push of blood as it flows through the cardiac system, and it exists in all blood vessels, but it's highest in the arteries and lowest in the veins. Why? Because the arteries have to have the most pressure to push it out, and the veins do not, because they're just carrying it back. So there's a blood pressure gradient that's shown in a picture, but it's basically what we just went over, talking about arteries, arterioles, and then moving down from there, so largest to the smallest. So if you can think about your heart being the biggest part of it, I would like to look at our body as a triangle. You're going to need this big artery up here, your aorta, and then it's just going to trickle down and get smaller, bring it back up, and then it's going to get bigger again and send it down, and then it's going to be smaller. That's a blood pressure gradient. So the blood pressure gradient is the difference between 2 blood pressures, and for the entire systemic circulation, it's the difference between the average or mean blood pressure in the aorta and the blood pressure at the termination of the vena cava, where they join the right atrium of the heart. So mean blood pressure in the aorta is about 10 millimeters of mercury. I need to look at that. It's 10 mmHg, if you said on the test. I doubt it's going to be on there. But let's see. High blood pressure is hypertension, and you might see it as HTN. She did say we need to know that, because if you see it in a nursing note, you're going to need to know what that is. So hypertension is bad because if blood pressure becomes too high, it causes a rupture in one or more of the blood vessels, and this, if it occurred in the brain, it will be a stroke. So your vein is only so big. If you've ever gone to the Dip or somewhere that has super good milkshake and they give you a super tiny straw, it will piss you off because it's super small and there's no way that you're going to get all that thick stuff through there. So that's the way that I kind of think of hypertension or blood pressure. You want it to be just right. You want your veins to be conducive with the amount of blood that's coming through. And different things can cause reflections in blood pressure, and we're going to go over that next. So chronic hypertension can also increase the load on the heart, causing abnormal thickening of the myocardium, and that can lead to heart failure. So if your body's working overtime, if your heart's pushing super hard to get this blood where it needs to go, after a while it's going to be exhausted, and that's going to thicken up. It's almost like a callus to the heart. Low blood pressure can be dangerous too. So if arterial pressure falls low enough, then blood won't be able to flow through or perfuse the vital organs of the body. Circulation of blood and life would cease. Massive hemorrhage drastically reduces blood pressure and can result in death. Hemorrhage meaning we're bleeding out, our blood pressure is going to bottom out, we lose it. Factors that influence blood pressure is blood volume, strength of each heart contraction, heart rate, and thickness of blood. So the blood volume is the direct cause of blood pressure in the volume of blood in the vessels. The larger the volume of blood in the arteries, the more pressure the blood exerts on the walls of the arteries, or the higher the arterial blood pressure will be. Less blood there is in the arteries, the lower the BP will tend to be. Hemorrhage demonstrates this relationship between blood volume and blood pressure. Hemorrhage is pronounced loss of blood, and decrease in volume causes your BP to drop, or sometimes they'll call it bottoming out. A major sign of hemorrhage is rapidly falling blood pressure. So if you have a patient and it's way below 120 over 80, you need to call 911. No, I'm just kidding. You need to get the doctor in there because this patient is probably about to bottom out. So we also have diuretics, and these are drugs that promote water loss by increasing urine output, and these are used to treat hypertension. As water is lost in the body, blood volume decreases and blood pressure decreases to a lower level. So basically, it's looking at it like you have too much fluid. So they'll give you a diuretic, and I can't think of one off the top of my head, the name of the medication, but they'll give them, and this will cause you to just urinate so much, and this gets that pressure off. It's going to lower your blood pressure. Volume of blood in arteries is determined by how much blood the heart pumps into the arteries and how much blood of the arterioles drain out of them. So diameter of the arterioles plays an important role in determining how much blood drains out of arteries into arterioles. And by diameter, it means how big this vessel is, whether it's stretched to the max, whether it's thin enough. That's how much pressure it's causing. And again, I just think of a shake, a really thick shake, trying to get it through a thin straw. So strength of heart contractions. Your strength and heart rate of blood pressure affect cardiac output and blood pressure. Each time the left ventricle contracts, it squeezes a certain volume of blood or stroke volume into the aorta and out of the other arteries. The stronger each contraction is, the more blood it pumps to the aortas and the arteries to get all the way down to your feet and back. The weaker the contraction is, the less blood it pumps. And strength of a heartbeat affects blood pressure. Stronger increases, weaker it reduces. Heart rate is the rate of heartbeat, may also affect arterial blood pressure. So when a heart beats faster, the blood enters the aorta, so the arterial volume and blood pressure would increase. And this is true only if the stroke volume does not decrease sharply when the heart rate increases. So often when the heart beats very fast, each contraction of the left ventricle takes place so rapidly it has little time to fill with blood and therefore squeezes out much less blood, usually than in the aorta. So if your heart's beating really, really fast, it's not grabbing enough blood to shoot out. So a lot of times your heartbeat's going to be lower. Blood pressure is going to be lower. Increase in the rate of heartbeat increases blood pressure. There we go. A decrease in the rate decreases blood pressure. Whether a change in the heart rate produces a similar change in the blood pressure depends on whether the stroke volume changes and by how much. So the next we see is blood viscosity, and viscosity just means thickness. So if blood becomes less viscous than normal, blood pressure decreases. So if a person suffers a hemorrhage, fluid moves from the blood into the blood from the interstitial fluid, and this dilutes the blood. So Cameron, this one's for you. I like to think of it as sweet tea. If you are suffering from a hemorrhage, if you're bleeding out, there's going to be fluid that comes into the blood from your interstitial fluid. The interstitial fluid is going to kind of rush in as like a second mechanism. It's going to come in and kind of try to save it, and it dilutes the blood, so it's not going to make it super thick. And nobody likes unsweet tea. It doesn't do you any good. Nobody likes watered down tea. It's not any good. So we know that if your blood is really thin, it's not good. saline solution is not a viscous liquid and cannot keep the BP at a normal level. Polycythemia can occur when oxygen levels in the air decrease and the body attempts to increase its ability to attract oxygen to the blood. And this happens when working at high altitude. So polycythemia, we know, is too many red blood cells. So if you're bleeding out, just say you've been shot, you're bleeding out, your blood's running thin, interstitial fluid is going to come in and it's going to try to fill that space. And also your body's going to let go of immature red blood cells that aren't ready to come out yet. And that's also going to be why you have so many red blood cells. And I relate this to when my dog had polycythemia. I came out into the garage one morning and there was blood everywhere, like buckets and buckets of blood on the floor because her body had an infection. She got bit by a tick. And so in an attempt to help her, it started creating all these blood cells, sending them out that weren't ready because they weren't mature. They're not even carrying oxygen. They don't help her, so they're coming out. So this can also happen when you have a hemorrhage, when you've had an accident, when you've had a cut. Your body's going to do everything it can in different steps to try and perform what it can for you to maintain homeostasis. So resistance to blood flow is another effect in this. Peripheral resistance is affected by many factors, including vasomotor mechanism or vessel, muscle contraction, or relaxation. So if you have vasoconstriction, it's going to be harder for you to get that blood flow through. And if you have vasodilation, it's going to be a lot easier. But your stroke volume and your viscosity level and stuff might be a little different. Fluctuations in arterial blood pressure, it varies within a normal range, and a normal is 120/80. Central venous pressure, venous blood pressure within the right atrium or the low end of the pressure gradient that drives blood flow. Venous return of blood to the heart depends on at least 5 mechanisms, and that's a strong beating heart, adequate arterial blood pressure, valves in the vein, pumping action of skeletal muscles as they contract, and changing pressures in the chest cavity caused by breathing. So we're going to look at pulse, and this is pretty much the end of it, but you have different pulse points, and there are 9 major pulse points. We did these in our physical assessment checkoff, so we know that we know them. You have your superficial temporal artery, and this is going to be right here on the temporal side of your head. You have a common carotid artery on both sides, front edge of sternocleidomastoid muscle. You have your facial artery at the lower margin of the mandible at a point below the corner of the mouth. Then you have 3 pulses on your upper limbs. You have your axillary artery, which is your armpit. You have your brachial at the bend of the elbow. And then you have your radial, which is the most common. It's less invasive. We're going to come in and we're going to feel this on our patient. I can feel mine right now. Then you have 4 in your lower extremities. It's going to be 1 in your groin on the inside of your leg. You have a popliteal behind your knee. Posterior tibial artery, and this is behind the medial malleus or the inner bump of the ankle. You'll be able to find it. And then you have dorsalis pedis or dorsal pedis, and this is on the top of your foot, just on the flat part of the top of your foot. So at the very end, if you're following along with the study guide, we had a bunch of questions, and it really does help to do these quick checks because if you read through the chapters and you stop yourself every time you see a quick check and you answer those, do not move on until you know all of those quick checks because that is the review of what you just read. So if you are to retain anything, stop at the quick checks, make sure you know it, and then move on to the next part. And this also breaks up so you don't get stressed out. So you could read, do the quick check, make sure that you know what you just read, go take a break, go take a nap, go eat something, go for a walk, come back, read the next part, do the quick checks, and so you know that you know that. Then you know that you've laid your eyeballs on every single thing that you can lay them on before this test. So the other things that she talked about in class were the SA node pacemaker is going to be 60 to 100 beats per minute. Atrioventricular node or AV node is going to be 40 to 60 beats per minute. AV bundle or bundle of His is going to be 30 to 40 beats per minute. The subendocardial branches or Purkinje fibers is going to be 15 to 40 beats per minute. If you have below 60 in a heart rate, it's going to be bradycardia. And if it's above 100, you're tachycardia. And then she also told us, this is a very small part that we talked about, but people who have heart attacks before 50 have a lot less collateral circulation. And that is it for those 2 chapters. Is there anybody that has any questions before I go get my behind in the bed? All right, well, I'm going to go ahead and end it then.